So this is the 6th of 7 webinars that we're doing around kind of innovator toolkits offered by Health Innovation Oxford and Thames Valley with select guests as well. This one's about NHS market access, and we'll go through a few details about what that is in a second. So this is the range of webinars which are available on YouTube and on our website if you want to see them. This one. We are doing the 27th of March one, and the next one in 2 weeks is around developing an NHS business case. So please sign up and join us for that one as well if you can do. If you've been on the previous ones, you'll see they're kind of building. There's a bit of a theme behind all of them. I'm going to do a really quick intro because if you've heard this before, you'll know all this anyway. So we're Health Innovation Oxford and Thames Valley, and we cover the Thames Valley. To look at kind of housekeeping thing, this session is being recorded, and we're going to put it on YouTube. We might clip a little bit of it out just to make it shorter. And we will send out a slide pack after, so don't feel you have to write everything down. They'll come as PDFs to everyone who's registered. You'll get a PDF pack with all the slides in it, just so you can see what we've said and talked about. So who is Health Innovation Oxford and Thames Valley? So we help deliver health innovation. We work with NHS, universities, industry. We're mainly commissioned by NHS England and the Office for Life Sciences. We're here about accelerating adoption and spread of innovation, doing great things around the NHS and with companies as well. We've been doing it for just over 10 years. We serve about 3 million people in our specific geography around Buckinghamshire, Berkshire, Oxfordshire, Frimley and Milton Keynes. We try to match higher value innovations with identified population needs, and we've got a few clinical priorities you can see there, but not exclusively those, but mainly those. And we're part of a national network of 15 health innovation networks that cover all of England, and we work with our colleagues in Scotland, Wales and Northern Ireland as well, amongst other international partners when that come up. And we used to be called Academic Health Science Networks, if you know that. And we've been relicensed until 2028, so that's great. So we're around for a few more years. I'm here to help you and kind of help industry and NHS and kind of academia progress. That's some of the great things we've done over the last 10 years. So today's session is around a toolkit for NHS market access. So it's really kind of understanding what it is the NHS wants, how to get to it as a market, if that's kind of where you want your innovation to sit. I'm understanding a few bits of that. And today, you might have seen, we've got a special guest speaker, which is Tom Cook from Quiddity Health. You can read the background there, but Tom is a cardiac physiologist by background and completed his MBA in 2022. He spent the last decade kind of in proposition market entry roles in public and private markets, and he's a wellbeing program manager at AXA, business development lead at Leva Health, and then a little bit at Orca doing value proposition for pharmaceutical companies. And outside of work, Tom is a National League assistant referee and completed the Isle of Wight Ultra Marathon in 2023. I think he finished it in 2023. He's not just finished that, so thankfully he's managed to get through. Those ultras can be quite a challenge. At Quiddity Health, who Tom works for, they're around connecting digital health innovations to ecosystems in a scalable way, providing value to end users. And they supported about 50 innovators to date, and they provide all or part of a UK commercial team, delivering expertise in end-to-end commercial processes, as you can see there, market access strategy, market engagement, and full pipeline ownership. So essentially all the stuff you would need to do for market access. And Quiddity has done lots of support for other health innovation networks and other innovators around the country. So Tom's kind of our expert, giving us that insight to what they do and how they do it. So I'm going to stop sharing my slides now and let Tom introduce himself and beyond what I've just done, and let him run the show from now. And we'll do some question and answers after Tom's presentation, probably about 1:15, a bit earlier around that. If you have some questions, we can answer them. Put them in the chat, raise your hand, but we'll get to that in a second. Okay.
So yeah, just a quick kind of recap of what Matthew's just said. So decade in digital health experience, a bunch of different roles, mainly commercial, but have worked with everything from large corporates with the likes of AXA all the way through to small startups. So Leva Healthcare, looking at bringing them from Denmark into the UK market. Particularly good use case with regards to a digital coaching solution that helped create national frameworks for weight management, diabetes prevention and diabetes remission or pathway to remission programs, all three of which national frameworks exist today and providing services on a countrywide level. What we really wanted to dig into today is a bit of a focus on actually, is the NHS the right customer for you? And there are a number of reasons for that. UK healthcare is very attractive to global and UK innovators, and there are tons of really positive reasons for that. One being how much money we spend. Nearly 300 billion. This was a 2022 total UK healthcare spend. And that's across all segments. That's looking at the NHS, it's looking at private markets, it's looking at private hospitals, pharmacies, all those kind of different segments. And it's a really important note for us just to say that when we're looking at UK market access and market entry, whether the NHS should be on your roadmap, how much it should play in terms of your commercial strategy. Should it be everything? Should it be part of? And lots of that depends on ultimately the makeup of your company. You know, what have you committed to investors? What are the commercial targets that you're trying to work towards? So the quicker we can get that information and intelligence across to you guys, the better ultimately, because it's going to save a bunch of really difficult conversations downstream, particularly if, you know, the investors are not necessarily health tech focused and don't necessarily know what commercialization within a market like the NHS might look like, for example. So just to give a bit more detail to what those market opportunities are. So as we said, the NHS is the major part of our ecosystem, as I'm sure you all know. About 89%. There's obviously some crossover with things like private hospitals and clinics, which are playing more and more of an active role in supporting the NHS with the capacity demands. This diagram also updates very, very regularly. So one of the things that is also more prominent now and most recently is the pharmacy channel. So I'm sure a lot of you have read recently about the pharmacy first model, which is encouraging patients to go to their pharmacy for certain medications as a first point of call and prescriptions, as opposed to going through the GP. So there's things like that, which would lead to pharmacy being more kind of connected to the NHS pathway now. And there are also a bunch of others in terms of the corporate market. So looking at employee benefits, direct B2C, which is a great option for lots of products, and different life science and telehealth options as well. I want to break down the NHS just a little bit, just to give you a bit of knowledge for those who are not fully aware of how it's broken down. The NHS is broken down into 42 ICSs, or integrated care systems, which have overarching integrated care boards. The integrated care boards are the legal entities that you're able to contract with. The ICSs are systems that bring together a bunch of providers locally to provide healthcare services to that geography. Now that generally, when we're looking at primary care, gets broken down into what we call primary care networks. So these generally are groups of GP practices, of which we have 1,250 roughly primary care networks that exist in the ecosystem. And from a commercial strategy perspective, it's absolutely acceptable to engage ICSs or ICBs directly, PCNs individually, or even going a step further and looking at GP practices where we're currently at 6,500 roughly. Now, the interesting note here is that just a few years back, we were in excess of 8,500, 9,000 GP practices. So that number is massively in decline. And what we're seeing with both PCNs and GP practices is the amalgamation of them to create super GP surgeries or super PCNs, which ultimately enables better shared resource, better shared funding opportunities, and pooling of those resources and funding across wider geographies to enable better delivery and better care services for the patients. So to kind of balance things just a little bit, there are some barriers to overlay the massive opportunity that the NHS and the UK health market clearly provide to us. These barriers are really important to understand and be aware of from as early a stage as possible. Our system is vast, complex, and interconnected. That has benefits, but it has barriers. Some of those barriers ultimately lead to things like a challenge on focusing the relevant market segments. Is your product solving a problem for primary care? Is it physicians or clinicians? Is it a patient-led service? Is it something that's hospital efficiencies, for example? We work with a hospital asset management solution that's end goal ultimately is to provide greater efficiencies within the actual hospital itself. So what is your product solving? What problem is it solving? For who and to what value? And we'll come on to that a little bit more later on. The NHS is super complex. The concept of coming into the market and being able to find a region or find an early adoption opportunity and then scale very quickly is just not going to happen. There are super opportunities with the likes of Health Innovation Network, Oxford, for example, to give you a really, really good grounding. But the scale after that, in terms of where the rest of your market lays, is really important to appreciate the complexity of it and the complexity of being able to kind of diversify across the ecosystem, because you know, one of the great benefits and one of the great values that we have in the UK is the diversity of our population. So what lands in Oxford or Oxfordshire or the Health Innovation Network region that Health Innovation Network Oxford are providing support for example, is very different to that exists within London or Manchester or Yorkshire, for example. Reimbursement models are often quite complex in terms of how they work, particularly when we start bringing in frameworks and tenders, which are, you know, towards the down end stream of where we're looking at. But having flexibility with reimbursement models is really important. We're a big fan of not utilizing free pilots at all, because ultimately, if you pay for something, you're more bought into it, and the value of that is clearer. But ultimately, going in with kind of full pricing on day one is going to cause you problems, and ultimately could be the reason for you not engaging an ecosystem. That ties into lack of knowledge of relevant commercial models. So again, we talk about early adopter pricing for those first opportunities. There might be 3 to 5 that you might commercially identify as relevant and value add, particularly where you might have key opinion leaders, KOLs, for example, that are stationed in those geographies. Once we've got over that initial phase, complex, resource-heavy access to funding and bids, we're super fortunate in the UK that we have lots of access to funds, bids, grants, likes of the Health Innovation Networks themselves, Innovate UK, SBRI, UKRI, lots of different access opportunities to funding, but they aren't overly clear often, and knowing where they are and when they're available is pretty critical to your commercial success in the market. Procurement and governance, I know you've had a session on this already, so I won't allude on this too much, but what I would say is, we've been in a position where we've had deals to the value of £500,000 or more that have fallen on their face because of governance issues or regulatory items that were thought to be in place but weren't. The NHS is an ecosystem that's super busy, and so if you get these people to a point of signing a contract and you're missing something, you won't have a great deal of grace period. So understanding the requirements, whether it be CE marking, cyber essentials, medical device requirements, DTAC, whatever it might be, having that knowledge and expertise early on is really important, because some of those things take months or even years to get fully in place. Understanding the network for partnership utilization. UK is fantastic for collaborations and partnerships. So part of the onboarding process that we do is, yes, identifying competitors, but also understanding opportunities for collaboration, potentially where you've got more mature collaborative opportunities for you to kind of piggyback. That's super helpful. And timing, which we'll come on to later on. But ultimately, the NHS financial year is about to finish in about 4 days' time. So knowing when to engage the ecosystem in terms of when budgets are available and when they're planned for and when they're being spent is an important aspect to consider. I'm going to move on to stakeholder management, and the reason for this is, often when you have an off-the-shelf service or a consumer service, it's selling a service to a person, it's a transactional sale, and it's pretty easy and simple to manage. We find with the NHS particularly, but also in private markets, that getting the right stakeholders around the table as quickly as possible is one of the most critical deal success factors that you can reflect within a pipeline. This is a pilot example for a radiology client of ours. Around 8 different clinical and IT and governance stakeholders are required, everything from funding support, primary care stakeholders, a stakeholder or representative in the ICB, but also at trust level, looking at system-wide champions, for example, from a clinical perspective. It's really, really important that these people are around the table as quickly as possible, because without them, your route to market is just going to be delayed and your deal timeline is just going to be delayed. When we set that up to an enterprise contract, you add, in this case, from a radiology example, NHS England with central funding within the imaging network, but equally project stakeholders at an imaging network perspective. So you've got another 2 buckets of people you need to have involved. There's potentially some maturer stakeholders that you need to bring in with regards to authority around budget and around making things happen. So with that in mind, quick visual map of the different groups of people that you might want to consider to get involved with. The average number of senior stakeholders that it took to close deals within the NHS last year was actually 11. So 11 budget holders or senior managers or budget stakeholders that you need to have on board from a very early stage to get deals across the line. And this isn't meant to scare or frighten you away. It's just meant to educate on what it actually takes to sign contracts within the NHS particularly. Having these people on board from as early a phase of the journey as possible will really help you to reduce that time from engagement through to deal closure and ultimately having that revenue in the bank. So the fun stuff, how do we grow and spread at pace? I mentioned timing earlier. Timing is pretty crucial with the NHS, and it's for a number of reasons. Firstly, the financial year, which runs from April to March. So if we kind of take this diagram right to left or back to front, if you like, right now we're in that decision phase. Historically has been underspent to utilize those kind of sub tender or framework threshold budgets of circa 5, 10, 20k. This year's been a little bit different with the strain on the ecosystem, so it'll be an interesting thing to see how that progresses moving forwards in terms of the next couple of years. But historically, little pots of money that are left that need to be spent would be able to be gained this year, or within those next kind of couple of days as we are now. Then you go kind of back to the left-hand side of the diagram, which is actually the start point of the financial year for the NHS, so April to June being Q1. This is a doing phase, everything that's been planned and committed to in the previous year. So I'm sure a few of you have seen the ICB strategic documents that exist publicly. There are also some more local PCN strategies that exist. What are the priorities of the of those individual geographies, and how does your solution tie into those priorities? That doing phase is really critical to start the relationship build for the next year. And if you're fortunate to have had contracts that have been awarded in the previous year, it's a doing phase to mobilize those contracts. As you start to go into summer, so July to September, albeit summer holidays, so lots of people are away, it is a key planning phase. You know, we've gone through that doing phase. The things from the previous year have been mobilized. Now we're looking to plan for the upcoming year. So that's the time to really kind of foster those relationships, really try to build that evidence base and the kind of case study base that you might have, and really have a good plan of action for moving into the showcasing phase, which is October to December, looking at the real strategizing, budgeting, commitment phase for different contacts and projects. This will be one of the busiest times of the year in terms of market engagement. Really important to consider some things here around sort of winter pressures. September, October tends to be also a really big showcasing phase in terms of the conferences. So things like HET, Confed, which this year's in the summer, but there are a bunch of conferences around that kind of July through to October time that are pretty important to consider. And then ultimately back round to Q4, which is again that decision-making phase. So really when we're looking at commercially going from 0 to 100, so take the NHS out of it for a second, this is just general market access work. Having that kind of strategy from the start, what markets are you prioritizing, what are your objectives and timescales, what's kind of your competition and collaborative opportunities, have your commercial model and have your resource nailed down. Lots of that will be kind of committed to already in terms of investors, funding, commitments that you've already made. But if not, really try and drill into that detail as much as you can, as early as you can. And that includes the grey bar at the bottom, which is things like regulation, procurement, governance, as we've already mentioned. Then you go into the commercial process. So for those of you who are commercially minded, this will be very familiar to you. For those who aren't, it's really critical in the NHS particularly to have that discipline and structure of market engagement. So looking at launch prep, who your audience is, what your message is to each of those audience profiles. If you're speaking to a clinical or medical director at a PCN versus if you're speaking to a business transformation lead within an ICB, they're very different value propositions based on what those people are wanting to see versus what a tech or IT lead might want to see, for example. So you have to speak differently to those individual personas and show that you've got those boxes ticked off. Moving into kind of lead gen, deal progression to closure. So it's normal pipeline progression, lead gen from direct prospecting, network access or inbound access, depending on your products or solution. Deal progression, so really looking at people who know the NHS, know how to engage the market. If you're from sort of retail or other mechanisms or other markets, coming into healthcare and health tech can be quite a surprise. It's very, very different in terms of the expectations. So people with NHS sales experience and BD skills are really, really important. And that's because the multi-level account and multi-stakeholder engagements that are needed to effectively close pipelines and deals, and then ultimately closure. One thing that people often forget with the NHS, particularly again around closure, is that's just the kind of start of the journey, if you like. Once you've closed a contract, if you don't implement it properly, it will fall on its face very, very quickly. The amount of free pilots, for example, that we see that get closed from a contractual perspective, but never get fully implemented because they couldn't get the resource requirements is scary. So you feel like you've done all the hard work, but then you essentially just miss the opportunity. So understanding the needs for implementation, what you're trying to gain from those opportunities, is it commercial, is it evidence, is it just experience, are all pretty critical elements. So I'm going to move a little bit into qualification framework, so really drilling into the commercial element of this. So again, apologies for any of you who are particularly commercially savvy, commercial directors and the likes among us. But what we tend to find is a lot of innovators and founders, CEOs, don't have the commercial background. They have a clinical background or they have a problem-solving background, and they're super good at knowing what problem they're trying to solve and for who. The challenge they have is how do you create a pipeline of opportunities to maximize yourself commercially to give you an opportunity to be commercially viable as a business. So the purpose of this is really to drill down to that and looking at a qualification framework. Now, the thing to mention with qualification frameworks is there are many, many different options, and some of them are personality driven. So you'll get those old school car salesman type profiles. You'll also get kind of partnerships, people who are very focused on partnerships, collaborations, and opportunities. And the truth is there's a need for lots of different variations of that based on the personas of people that you're talking to. We particularly find the BANTC model very, very helpful. We've taken out their C and put our own in, which is champion, and I'll come on to that in just a second. But if you can quickly get to what's the spending ability of the stakeholder you're trying to engage, so what's the budget authority, what's the actual authority of spending that budget from a decision-making perspective, what's the immediate need for that population. So if we take the UK at the moment, strategic priorities around virtual wards, mental health, a bunch of the other ones, CVD, for example, that Matthew mentioned in regards to Oxford specifically. But what's the immediate need and urgency for that population or for that stakeholder? If there is an urgent need, you're far more likely to drive that opportunity to commercialization much more quickly. And timing is really important, as we've alluded to already. If you trying to engage the market from a completely brand new perspective with a new product, a new solution that has no evidence between January and March, you're going to really struggle because people are essentially trying to get hold of those final budget pots. Relationships have been ongoing for 6 to 9 months. So it's not to say you can't do it. But if you're expecting things to move quickly and you have a very immature value proposition, you will really struggle to engage the market at that time of year. Champions, we cannot emphasize enough the value of champions. I'm going to hold off on that for just a second because I've got another slide that goes into a bit more detail. But if there's one thing for you to take away from today, having a champion internally alongside a key opinion leader who gives you credibility and gives you influence on the inside will be the number one factor for how you can rapidly accelerate with respect to what rapid means in the NHS market, particularly any opportunities that you have. A slightly different approach to this is the challenger sale. Again, anybody in sales will probably have heard of this, but it's the concept of not just accepting no as an answer and being able to challenge, but challenge on the foundation of being educated and knowledgeable about your solution, its evidence, and the ecosystem that you're trying to work in. One of my biggest personal kind of pet peeves with digital and digital tech in particular is that there's an expectation that we just keep implementing extra digital tech and layer digital tech onto what already exists. The reality of it is that's never going to work because the ecosystem as it is today is broken. So we need to improve and optimize it, not just layer more things and more complexities. There's some great work going on in Cheshire and Mersey at the moment in the CVD pathway there, which is really looking to take out the clinical pathway, completely unpick it, identify what digital solutions exist to support and improve that pathway, integrate those digital solutions into the clinical pathway and retrain the staff associated to those clinical pathways. It's a really super way to look at it. Yes, it takes a bit more time, probably a bit more effort, a bit more funding, but in terms of optimizing our ecosystem, that's a really good way to do it. The challenger sale, by having knowledge of, for example, the 4 priorities that Matthew showed at the start, enables you to challenge the status quo of conversations you're going to have. People in the NHS, those stakeholders that everybody's trying to engage, business leads, transformation leads, digital directors, clinical directors, medical directors, etc., etc., etc. Everybody's trying to get these people's time. If something doesn't align to them very quickly, it's quite easy for them to say no because they have to prioritize so strongly. If you can push back on that based on real evidence, real knowledge, real understanding of what their ecosystem is, what their real challenges are, what their QoF metrics are in terms of failing to achieve certain point areas, certain funding opportunities, CQC things where they're not hitting targets, for example. If you can frame your way and frame your solution in a way that's very relevant to their priority areas and challenge them if they push back on that with knowledge and intelligence, you will land very, very well because it gives massive credibility to what you're doing. I said I'd come back to the champion point. Probably around 90% of the engagements that happen around your solution and the ecosystem you're trying to enter will happen when you're not there. So ultimately, this champion or group of champions will be fighting your corner when you're not at those meetings because they're internal meetings. If you have a very good champion who ideally has power and influence, they have a track record, they have something to gain, and they have access to the buyer, you will find that your success rate with deals goes through the roof because of that fact that 90% of these engagements are going to happen when you're not there. Yes, you can give your passionate story, the reason why you built your innovation, the reason why you're involved in your innovation when you get that 10% airtime. But in reality, that 10% is 10%, and it's really easy for things to fall through the cracks. So it's super, super critical that once these champions are identified, they're on board, they're fully trained up, you almost see them as a member of your sales team. So applying this to the sales cycle, different pipeline stages, which I won't go into, but everything from prospecting, lead generation through to close one. That's everything from discovery through to sign off, procurement, and as we mentioned, implementation. But understanding what key elements of that BANSI model you need to get to at what point of the model. So we said need very early on. If you know what problem you're solving, to what value and to who, your initial discovery call and your pitch is going to be much, much easier because you can tailor it directly to their priorities. Add then the champion that we said very early on, authority, time, and budget become downstream opportunities. So last but not least, and then plenty of time for questions, which is the most valuable bit, I hope. How can we accelerate deals more quickly? So we've mentioned about compliance. I'm not going to harp on about that, but it's really, really critical you understand the compliance landscape, the regulatory landscape. What are the needs for your solution? Integrations, do you need to integrate with EPRs like Epic and Cerner, electronic patient records, for example? Do you need the support of companies like PKB? Do you need the support of any of the other stakeholders that exist in the market? Those integrations can help speed up the process, but they can also help open opportunities from a collaborative perspective. So really, really important that you're aware of what's needed there. Multi-stakeholder engagement. When you're on a call, early doors, if you only have one person on that call, the likelihood is that person isn't going to be able to make the decision on the budget with the clinical input, the IT input, all of the other bits and pieces that are required. So don't be afraid to ask. Ask those questions in terms of who else needs to be involved. How do you get them involved? What can you do to help? What can you do to support? They'll often tell you. They're quite happy to get other people involved in the discussions. But if you have that discussion early doors, it's one person, you don't engage the wider population, you're only going to delay yourself downstream. Having a less complex proof of value option is really, really important. It's not to say you want to devalue your product, but your gold standard product as it exists might be too complex to come in from a use case perspective and a test perspective. So is there a less complex proof of value option that you can provide? And then strong business case material and case studies. I know building a business case is the next session, so timing is very apt on that. But I can't tell you how much that is needed. We are on regular conversations with ICB digital directors and the like. And the amount of them that will come to us and say, we're only interested in innovations that have a proven business case that's been tested elsewhere because of our capacity resourcing to onboard new things. So the earlier you engage with that side of things, academia, health economists, for example, and again, it's where the health innovation networks are super, super valuable. And the quicker you can engage with those main opportunities to accelerate your business case, the better. And that's me. So half an hour in, we've got plenty of time for questions and discussion.
Thanks very much, Tom. That was really, really helpful. I hope people kind of, I'm still distributing some notes here as well. So really useful kind of methodology and framework to kind of understand how you want to access the NHS. And I think, as Tom alluded to, that's not just the NHS. You can use it for any kind of complex system where you're going to have multiple people agreeing or kind of signing off on things. So Tom very kindly mentioned health innovation networks, including us. So we like to help people with those things. We do have health economists as our team. We also do co-applications for grants, so Innovate UK, UKRI type things, things that are NIHR pilots or things that we do evaluations on them a lot. So we do a lot of that stuff. So if you're interested in that, get in touch with us. Obviously, get in touch with Tom if you want some of the stuff that Quiddity can help with as well. But in terms of health innovation networks, we can do a ton of that stuff. So that's kind of that bit. I will stop sharing slides and we'll go to questions. I see there are a few in the chat. So we'll try and pick those up. The second thing is, if you want to ask a question, raise your hand and we can open up the mics and the cameras if you want to kind of do it live. But I'll stop sharing. You get more screen space. There we go. Okay, so a few questions in there. So I think, so Tom, I think the first one, there's a question here from Joshua about the sales cycle. So they're saying plenty of purchasing will happen in the January to March, deciding purchasing can still happen throughout the year. Is that correct? I mean, I can answer that one. Do you want to answer that one, Tom?
Yeah, I'm sure we'll have the same answer. Purchasing can happen at any time of the year. It just, in terms of the sales cycle, if you're trying to go in with a cold conversation in January to March, that's the point that most of us as salespeople will be trying to close off deals that we've been working on for the last 12 months. So the general kind of consensus is try and do your kind of setting your seeds, if you like. April to kind of summertime is a great time for that. Generally, the deal cycle within the NHS is kind of 6 to 12 months. So it just kind of means that by the time that end of year budget comes around, if there's a point where there is going to be urgency for spend, it will be then. But you're absolutely right. You can engage with the ecosystem at any point of the year, and people spend money all the way through the year. It's just the kind of timing and focus areas of when people's headspace is going to be focused on what kind of outcomes, if you like.
And to build on that one slightly, I think, Tom, you mentioned kind of this period now, January to March, end of the financial year, there may be underspends or money they can carry forward, and they might want to do some small scale purchases, like you said, £10,000 type things. If your solution is hundreds of thousands or millions, don't expect like a really quick decision in that January to kind of March time. That's not going to happen. It's very, very unlikely. What will happen is they'll be thinking about it and planning it through the year, maybe from implementation to the end of the year or the beginning of the new financial year. They get new kind of capital money comes in April, then they can actually buy it in April. They might be planning it in January, February, but they can actually buy it in April when the money kind of is clear. And they've done their own budgeting and internal processes around that. But yeah, it can happen anytime through the year. It depends what it is. And the other thing to mention is that sometimes there are pots of money that get made available throughout the year from government because they want to incentivize something. It could be anything. It could be virtual awards as a recent one. Other kind of initiatives. We're not saying billions here. We're talking maybe a few million across the country for them to do stuff. Sometimes if you have a solution that people know about, you can rapidly get in there. But it's a matter of getting engaging with those potential customers and systems really early. So thanks very much. There's another question here, Tom, for you again. So how do your company works with companies? What the fee structure is? If you can answer that one, if you can. It'd be great.
Yeah, of course. So we worked on a retained fee model. So essentially, we outsource a commercial team. So we are the full or part of the UK sales team for all of the clients that are listed on our website. I can name a few, the likes of Headspace, ImproveWell, QLog, Anya, who are a great little company. Most of these companies have come through Health Innovation Networks in some way, shape or form. I'm sure we have some that have come through Oxford and Thames Valley, but off the top of my head, I can't remember which. New Health are one that have come through locally. So yeah, there are a bunch of options, but yeah, we work on a retained fee basis and then success share metrics in terms of revenue share and things like that. So yeah.
I'm just realizing there's a few comments in the question and answer one as well. So we've got a chat, we've got a question and answer. There's one about finding areas with underspend on their frameworks. So I guess how you find that out. So I'll take that one really quickly, and then Tom, maybe you want to build on that too. Essentially, if you've got a relationship with a system or a hospital already going, they may be able to say, "Oh, look, it's actually March now. We've got an underspend that we can use, maybe 10,000." They can tell you what that is. Then maybe you want to kind of scale appropriately to what they've got to spend. So if your solution is really £100,000, they've got £20,000. Find something maybe they can buy for 20,000 to get the ball rolling, and then once you're in the door, you usually have a much better success rate going forward. Tom, I don't know if you want to build on that as well.
Yeah, I just asked the question, relationships. Publicly, you won't see where underspend is available, and publicly what you'll see is that every ICB is 100 million or more in the red, pretty much. So the reality of it is there shouldn't be any underspend. Of course, that's not true, but yeah, people always get shy about asking the question. Finding out where your funding is coming from is really important. So figuring out if someone's a budget holder, where their budget is coming from, are you able to tap into that? Be direct. I honestly see so many people shy around the topic. Just ask them. You need those relationships in place first, but they will be willing to tell you stuff if you're willing to ask them. So just ask a question.
And kind of the flip side to that is if they do have an underspend and they want to spend it, it's really helpful if you as an innovator or potential supplier are able to do something for them. They'll be a bit disappointed if they go, "Oh, I found £20,000, but I need to spend it in the next month. Can you do something?" That's really when you can build some really good bridges by saying, "Yeah, I can find something for 20,000 to get that spend out the door for you." I mean, it sounds ridiculous when there's so many budget constraints, but sometimes a budget is underspent because they couldn't do everything in that year. So that happens. So yeah, thanks, Tom. There's a second question here from Lou, which is, who are the several budget holders and how can we find out how much budget they have for each issue? Tom, do you want to take that one, and I can build on it if it helps?
Yeah, budgets, again, specific budgets budgets, you need to ask the question. Very, very rarely will you see that publicly available, but they will be able to tell you what they've got if you get them on a call. In terms of the stakeholders that we're looking to engage, it varies by product. Again, it's hard for me to give a super generic view, but in terms of budget holders, you're generally looking at heads of directors, medical directors, clinical directors. You might get some business managers or business transformation leads that have some part ownership of budgets. That's sort of the level there and above that you really need to be looking at. And then, the titles are all slightly different by region. So, you might get a digital transformation lead in one region and it's just a digital lead in another, or it might be head of digital in another. So you have to have probably a variation of, I don't know, 4 or 5 prefixes with, probably 7 or 8 different title options, and combine all of those and target a lot of them is basically the process and structure we go through.
And I think just to build on that a little bit, it will vary. So an ICS will be different than an NHS trust, and with anything over a certain value, anything roughly about £100,000, anything that's going to cost £100,000 for the whole life of it is probably going to have some kind of tendering going on, some competitive thing. They've considered a few options. So you might say we're the only company that can do this, and then the pushback will be, well, there might be something that can do similar. But if you've got someone who's really keen on your product, ask them. If we had this on a procurement one we did earlier a few weeks ago, get them to give you the procurement lead so you can talk to the person who's probably most likely be able to get it through. So a clinical person is fabulous to get them engaged, wanting your product or innovation. But at the end of the day, it's very unlikely they sign off on the purchase themselves. They need to go through procurement or someone in finance who can actually make it happen. So having that conversation early, just say, doctor or this nurse has given me this concept, and speak to that procurement person. They're usually happy to explain how they can do it and what to do, because you have to follow it's public sector. They need to be really careful around that. So yeah, that's great. Thanks very much, Tom. Come off the Q&A. I'm going back to the chat one now, jumping back and forth. There's a question here around the new DPS frameworks, the dynamic purchasing system frameworks. And for you, Tom, are you seeing NHS access innovation quicker through these frameworks?
Be careful what I say here. The truthful answer is it's too soon to tell. I mean, if you look at things like the G Cloud frameworks, they don't often speed up access to innovation. They provide frameworks and structure to the ability to procure certain solutions. When it comes to digital, there are very few examples of solutions being mature and scaled enough for you to have a consistent theme with that. And I believe the purpose of these frameworks is ultimately similarly to that, to eventually have a central place where you can procure a lot of this technology. Reality of it is now the budgets don't align to that. People aren't using the frameworks, and a lot of the entry points for most of the innovations that exist are at that lower threshold level, as Matthew rightly alluded to, sub 100k. That could be anything from hundreds of pounds to 50k, 60k as a contract. So they all fit as direct awards, as we call them, outside of tenders and frameworks. So yeah, I would say at your stage, for frameworks to be developed and exist, that's probably a 3 to 5 year thing in terms of specific frameworks for your solution, but equally for your specific solutions industry, if you like, or focus area or vertical, to be mature enough from a digital integration perspective to have a consistent space on those frameworks where people are procuring your solution.
And a little bit of a build again. So if you went to our procurement webinar that happened a few weeks ago, there's been a new directive from NHS England. They want everything purchased through a framework, but there's kind of a grace period of this year. So from April 2025, just getting my dates right, they'll want everything to be purchased through a framework if it's available on a framework. So this is kind of a central kind of request that everything gets onto a framework of some sort. And the dynamic ones, like Tom has mentioned, are designed to be things that aren't closed. They don't just open and then stay closed for 3 to 5 years. That doesn't really help innovation in lots of ways. But the dynamic ones are meant to be, the new NHS supply chain one, they say quite openly it's for innovative things right now. So it's got to be genuinely innovative. It can't just be another version of something that's already out there. And once it becomes kind of business as usual, they expect it to go onto a business as usual framework. That's the language they use. So essentially, it's been innovative for a year or two. There's a few other on the market now. We'll put all 3 or 4 that are on the market into a business as usual framework like G-Cloud or the other kind of frameworks, and then trusts or purchasers can buy them off that framework. And the advantages and disadvantages of frameworks. Frameworks means you set a price, they can contract really, really quickly and easily, but you are bound by the price that's in there pretty much. If you want to do something a bit more creative, you might want to go directly to them. We'll have to see how that's possible. I imagine there'll be a bit of pushback from NHS trusts around that if they can't find what they want on existing frameworks. But yeah, good questions. So yeah, thanks very much, Tom. I'm trying to see if any more. So I'm going to check the Q&A and the chat. Feel free if you want to raise your hand. So like there's a little raise hand button in Teams. If you do that, we can open up your mic and ask a question directly if that helps. I think the thing to be aware of that I can't take away is the NHS isn't just one big homogenous organization. I think most people realize that, but there's not one person who can just make everything happen. They might have influence, but they themselves cannot make everything happen. You kind of have to do your legwork, working with whoever's going to use it, who can purchase it, who can integrate it, who can get it, the systems tied in. I think that slide you had, Tom, that was kind of showing all the people who have to be involved in something, integration here, you know, primary care network, ICS, secondary care, and everything else. And I can see that Tom has put in the chat here, he's put a link to the Transforming, so the Better Care Fund, so different kind of funds. That's kind of what I was mentioning before, is that sometimes NHS England will make available money. So they might say there is going to be £42 million available for X to be done. And sometimes they say we want every ICS, all 42 ICSs to do that. So you can think they're each going to get about £1 million. And actually maybe a little bit less because they've got to pay for other stuff around it as well. So you can then kind of think, this is what they're looking at. They're looking to buy something for maybe £750,000 at each level, and I could talk to every ICS I've been working with. So there's different ways they can do that. So planners in the NHS don't like that so much because obviously you can't predict that money coming through. You're trying to set your budget for the whole year based on what you know is coming in and coming out when the money drops in. So it depends kind of what the big initiatives are. You can kind of imagine winter pressures. There's always something to help alleviate winter pressures. And the summer, it's kind of about planning services, getting them up and running. I don't know if you had any success, Steve, or if you can put your question into the chat. That'd be great if you could, so we don't miss out on that. In the meantime, any other questions? I think we've answered the ones in the Q&A, and we've answered the ones in the chat. We're trying to get Steve working, but not yet. So I guess, Tom, so I know we've got a mix of kind of early stage innovators and kind of more established companies. I don't know from your perspective, if you've got, there's obviously a lot of content to what you presented today. If you're a very early stage innovator, you've just got an idea, you're just getting ready, what would kind of be your big strategy kind of points that you think people should do? Because there's a lot to take in there. Where should they start? I guess that's kind of be a question most people are going to be thinking about.
Yeah, okay, that's crikey, Matthew. That's a great question. So I always kind of draw back to basics. I mean, in terms of your solution, you know, really know what actual problem are you solving? For who are you solving that problem? Is it patients? Is it a hospital? Is it a clinician? Who are you providing value to? And what is the tune of that value? You know, is it that you save 5 minutes of time a day of a surgeon or a doctor or an admin person or receptionist, whatever it might be, or is it that you're, you know, making a hospital more efficient by being able to track stuff, assets, and hence you save a certain amount of money? That's the foundation of your value prop, business canvas, all the good stuff I'm sure you guys have all done already. But really being absolutely crystal clear on that, because if you don't know what problem you're solving for who and to what value, my argument is you don't really have a business, or you don't have a value proposition that's commercially viable anyway. The second stage to that, which is probably the more difficult piece, is then understanding the timelines of when these things need to be initiated versus your funding and versus, you know, and there are tons of ways that you can go about funding. Is it angel? Is it VC? Are you going to find other creative ways? Is it just grants? And a lot of that will impact some of your ability to look at product development or regulatory or what have you. But having that all kind of mapped out, all of these different streams of things that you're going to have to do at some point, probably over a 3-year period, something like that. At what point are you engaging in each of those things? What are the kind of key milestones that you need to achieve to take that next step? And how are you going to make sure that you've got enough money to get to that point? Because when clients come to me and say, you know, well, we haven't got any UK presence yet, but we are planning to make 150 grand revenue in year 1. What do you think? You know, I'm kind of very honest and very transparent in saying you've got probably more chance of winning the lottery, to be honest, in terms of how the ecosystem is right now and what I can see about your solution. So being realistic about what your expectations are is really important. And I think there is a bit of a mindset shift in terms of investors, particularly in terms of understanding the market in a better way and being realistic about that. Because whereas previously, post COVID, we just opened the pockets and everybody was being funded to the tune of millions on the back of promise. We're 4 years down the line now, and that materialization has been very, very limited. So actually being able to know and show experience of a market, be realistic about when you expect to commercialize certain streams, whether it be the NHS or whether it be private markets or whether you've got a B2C proposition, will land better and put you in a better position with any investors or any kind of people that you're chatting to, because we've seen countless examples over the last 3 or 4 years of companies running out of runway, great products, great solutions. The reason they failed wasn't because of the solution or the product, but because of their, I say, poor planning, potentially lack of knowledge about the commercial reality of the environment we find ourselves in right now. And that's only been compounded by, wars breaking out globally, pending election this year, obviously a bunch of other stuff, recession being announced. Having an understanding of lots of those things is critical to you being able to be commercially viable, because if you don't have enough money to keep your business going, doesn't matter how good your idea is, it's completely pointless, right? So yeah, a couple of bits and pieces there, but hopefully that kind of makes sense.
Great, thanks very much, Tom. I think there's lots to consider, and I think kind of one of the key things, unfortunately, is kind of the reality is that you have to know if it's going to save money to whoever's going to use your product, especially for the NHS. So it's either save money or costs about the same as something else. So even if it's better, they need to know kind of what it's going to cost to be better. If it's cheaper, great. If it's better and cheaper, that's fabulous. If it's better but more expensive, the NHS is a little bit more hesitant around that, and they really want evidence. So I think one of the interesting slides that Tom presented was the NHS, yeah, it might be 89% of the spend. That still leaves about 20-30 billion that isn't NHS, 10% of that. So that's a lot of billions, which you could still access either direct to customers, through pharmacies, through corporates as well. So if your product meets those needs there, the NHS doesn't have to be your only customer. It might be great to have them, but the NHS is quite hard to sell to. They are quite constrained in what they can do as a public sector body, but you can actually go through other channels as well. And if you remember, if anyone joined us on our kind of a regulation webinar recently, one of the comments there was time is money, which is kind of obvious. But if you've got something that you can start selling now and making some money without being fully regulatory approved, because it doesn't need to be, if you start getting some of that income in and then developing your fully regulated product, you start getting some revenue streams, can demonstrate that to investors, to potential customers. So it's not just the NHS. So you can look at the NHS in its singularly, that's up to you. But if you look at kind of more broadly, how could this be used? Could it be done in different areas? So a little bit of kind of customer segmentation to say which customers need what kind of things. That's another way of looking at it from a commercial perspective. Okay, I don't see any more questions. So unless someone wants to raise their hand or ask more questions, I think that's been really great, Tom. So I think you've answered a lot of questions. So Tom's going to get his slides over to us, and we'll send them out to all the people registered. You'll have those, my slides as well, which are less interesting, but a bit more kind of background. We'll send those out to everybody. We will make a video available of this webinar and put it on our YouTube channel under Health Innovation Oxford and Thames Valley, so you can watch it back. You can speed it up, slow it down, whatever you'd like to do there. That'll be available too. And we've got another webinar in 2 weeks, which you can sign up. I think Rochelle's put the link in there. You can find on our website as well. So I'm going to let you all have a little bit more of your lunch hour back. And I'm going to thank Tom very much for being our guest speaker today. Really, really insightful, really great information. I really kind of think food for thought for anyone kind of looking to work with the NHS, to understand kind of how it's structured, but also kind of what you can do within that. So having a plan and everything else. Okay. So thanks very much, everybody.